in a pace that I think were unimaginable 6 or 7 months ago. We've also seen the highlighting of disproportionate impact of COVID on ethnic minority communities in many countries, and also, of course, on ethnic minority healthcare staff with tragic consequences. And that's kind of really, I think, highlighted the impact of discrimination and racism upon health outcomes, and presented us with a very immediate challenge of how we bring about transformation rather than reverting. We've also seen, I think, the development of team working at local level. I think what I've observed certainly is there's been some necessary command and control at the top. For example, in London, all of the chief execs are meeting twice a week with each other to ensure that they're coordinating services effectively during COVID, having hubs for cardiovascular surgery or urgent cancer surgery, and at the same time devolving responsibility to local teams, particularly to clinicians, to make decisions. And some of that local innovation has been extraordinary in terms of scale and pace. And we've seen the development of much closer team working in many cases, with teams being more stable, being more supportive, more camaraderie, and also using huddles, quick reflection time to learn how can we respond quickly to this challenge and what do we need to change. And we've also seen, I think, an outpouring of compassion across the 5 nations of the UK and Ireland. Compassion from staff to patients, compassion between team members in healthcare teams, and compassion from the general public to frontline workers to healthcare staff. In Ireland, there were 70,000 volunteers to help the health service in just the first few days of asking. And I want to draw out more on those 3 themes of compassion, team working, and reflection, because I think they contain important messages for how we lead in the future. So if we could go to the slides, please, Tina. So compassion is one of those terms that feels like it's taken for granted, and it seemed to be a good thing. But we have learned a lot about compassion in healthcare over the course of and last year there was a review published by 2 medics in the US, Tresiak and Mazzarelli, a very thorough review of hundreds of research articles where they looked at the impact of compassion in healthcare. And I'm going to show you just a few bullet points. I'm not going to go through all of them, but the results tell us something remarkable. So we see, and all of these bullet points refer to RCTs or to meta-analyses. So the first one refers to research showing that when anaesthetists are, as it were, asked to go in to see patients pre-surgically, to be really compassionate in their interactions. And what that reveals is that those patients who receive, as it were, that intervention, as opposed to sedatives pre-surgery, are calm but not drowsy, as opposed to those who simply get the usual intervention and sedatives, who are drowsy but not calm. And it's also associated with less pain post-surgery and a shorter length of stay. And we see that patients randomly assigned to compassionate palliative care survive 30% longer. This was actually a study of changes in quality of life as a result of compassionate interventions, rather than analysis of how long people lived. And those patients with early cancer diagnosis, terminal cancer diagnosis, who received the compassion intervention survived on average 30% longer. And we see similar effects, remarkable effects, in relation to long-term conditions like diabetes, HIV. And remarkably as well, we see that contrary to what many clinicians think, indeed the majority of clinicians think, compassion doesn't lead to a longer encounter length. And also, when clinicians are prompted to show compassion in their interactions, in their encounters with patients, it has a positive effect on their well-being, reducing anxiety, depression, stress. And compassionate interventions appear to cost less because they are associated with better adherence to therapies, with a lowered need for onward referrals. And overall, what we see is that it appears that compassion is probably the most important intervention in terms of its impact in healthcare. The size of effects is greater than the effects of aspirin in heart attacks and of statins in the 5-year of a cardiovascular event. So compassion is hugely important. What does the word mean? Well, behaviorally, if I'm going to be compassionate towards somebody who is in distress or in pain, there are 4 elements to that 4 elements of behavior involved. First, I have to be present with the other person, to pay attention to them. Nancy Klein uses a wonderful phrase, listening with fascination. So listening with fascination to the other person. Second, it's about seeking to understand the causes of their distress or their difficulty, ideally through a dialogue rather than us as experts, as it were, imposing our understanding. And third, it's about having an empathic response, a felt response, so we mirror their pain, discomfort, because that gives us the fourth element of compassion, which is helping or serving. And what the neuroscience studies show us is that when we ask people merely to be empathic or sympathetic in their interactions with someone who's in distress, it's associated with the activation of the pain centers in the brain, not surprisingly, because people are, as it were, mirroring the pain of the other. Whereas when people are prompted to be compassionate in their interactions, then that's associated with the activation of reward centers in the brain. And that makes sense because we are hardwired to be altruistic and compassionate, because that builds social cohesion, belonging, and that's protective for us. And compassion is the first and foremost requirement that patients have of their healthcare providers. Somebody who listens, is sympathetic, and helps me. So the challenge for us is how, as leaders, we can create the conditions where those we lead will be compassionate in their interactions, not only with patients, but with each other as well. It's about creating cultures of compassion. So that means that leaders, well, the first thing to say is that culture is a consequence of every interaction by every one of us every day. How warm we are, how kind we are, how irritable we are.
Okay, we seem to have lost Professor West there for a moment, but please bear with us.
What they reward and what they model in their own behavior tells us what it is they value. So it's important our leaders model compassion in their leadership, and that means leaders who pay attention to those they lead, who are present with them, leaders who seek to understand the challenges that those they lead face. And the challenges of healthcare staff are enormous. In most of the healthcare systems across Europe, stress levels amongst healthcare staff back in January were at the highest they'd ever been. In the UK, we had well over 100,000 vacancies amongst healthcare staff, 1 in 10. And intention to quit amongst doctors and nurses were at the highest levels ever. And then the pandemic struck. So of course, as leaders, we should be seeking to understand the challenges that those we lead face. And it's important that we also empathize with them, that we're emotionally intelligent in our interactions, and that we, most importantly, seek to help them by removing obstacles which get in the way of them doing their jobs effectively, or ensuring they have the resources they need, whether it's staff, equipment, PPE, the skills that they need to do their jobs effectively. And I think what's important is to recognize that these 4 behaviors, they describe what we understand compassion to be, but they also, when we review the literature on leadership across organizations internationally over the last 60 years, reveal that these 4 behaviors are the most important behaviors in relation to effective leadership. And in one sense, it's no coincidence, because they're behaviors which enable us to connect with each other, being present, listening, understanding, empathizing, helping each other. It's how we connect, how we build a sense of belonging. And belonging is probably the most important motivation in human behavior after our basic biological needs. We're more likely to die from the effects of loneliness than we are from the effects of obesity or smoking. So it's no coincidence that what constitutes compassionate and effective leadership is also what constitutes compassion. And these behaviors, these 4 behaviors we know are related to effective leadership. We also know that when leaders behave this way, it has an effect on those they lead, and in turn on those they serve. So we see in the private sector the links between leaders displaying these behaviors, staff well-being, quality of service given to customers in the private sector, customer satisfaction, productivity of the organization, and profitability. And in the healthcare sector, that's also true. We've been running a staff survey in England for the last 15 years, and we have had over 250,000 responses every year during that period. So we've been able to do the most sophisticated longitudinal analysis. And what that reveals is a similar pattern. We see that actually the best predictor of the performance of healthcare organizations in England is their staff experience. When staff report high work pressure, patients say that they're treated with inadequate compassion, they're not respected, they're not treated with dignity, they're not given the privacy they want. And when staff report poor health and well-being, high levels of work stress, we see subsequently in those organizations poorer care quality, lower levels of patient satisfaction, worse financial performance, and in the acute sector, significantly higher levels of patient mortality. So compassion is important for effective leadership. It's important for the outcomes we seek to deliver. But I want to emphasize that compassionate leadership is not simply soft cushions and scented candles. Compassionate leaders have to have courage, because their focus will be on purpose and performance, because we're here to serve the people and the communities of our country. Performance management will be central in terms of how they manage. And it's not about taking some easy consensus way forward. When Nelson Mandela was released from Robben Island prison in the early 1990s, rather than go with the expectations of his hundreds of thousands of followers and lead them into a civil war against the apartheid regime, he went against them and insisted on seeking a negotiated outcome. And he, against all of the odds, achieved a relatively peaceful biracial South Africa. And it's also about, by the way, not just about individual leadership, but about institutions. It's about institutional compassion at every level of the health and care system. Compassionate leadership is also about having the courage to ensure effective leadership and inclusive leadership, and as Philip said, collective leadership, as well as leadership across boundaries, because we're here to serve the people and communities of our country. Then it's really vital that leadership is effective, and compassionate leadership is the compassion is ultimately for the people we serve. So compassionate leadership is about ensuring there's effective direction for our teams, our organizations. It's about ensuring there is alignment of efforts around that direction rather than efforts being dissipated on inappropriate, unnecessary tasks. And it's about ensuring the commitment of those we lead, their trust and their motivation. And I'll say more about that in a moment. And if leadership is not inclusive, then it's not compassionate. We've seen the devastating effects of the COVID virus on minority ethnic groups during this period. And I do think now is a moment when the light must get into all of our health and care systems and indeed our societies, and we address this pernicious chronic problem of discrimination. And that's about inclusive leadership. You know, I may be a leader where 3 people in my team rate me very highly as being inclusive, and 2 who happen to be Black may rate me as below average. So my average scores above all may put me, you know, looking reasonably good in terms of inclusivity, but I'm failing as an inclusive leader. And I think we have to address those issues. And that's about ensuring that our organizational processes are addressing issues of discrimination and racism, but leaders are being trained in how to lead, to be inclusive, to ensure equity and positive diversity and also universal inclusion. And also it's about ensuring that everybody in our teams and organizations takes responsibility for creating an inclusive, positively diverse environment. Compassionate leadership is also requires courage. It means not taking what I think is an easy opt-out of command and control. It requires nurturing the collective leadership, everybody's right and responsibility to show leadership, to have shared leadership in teams. We still have a hierarchical leader, but we are utilizing everyone's skills and abilities. You know, it's extraordinary that we probably have in healthcare the most motivated and skilled workforce in the whole of industry, yet we manage them largely through extensive hierarchies and command and control. And it's about system leadership, being compassionate in how we work across boundaries, working effectively with other teams, with other departments, with other directorates, with other organizations, with the social care sector. And always asking the question, how can we help you so that collectively we deliver effectively for the people of the communities we serve? So compassionate leadership, I think, is fundamental as we move forward, and it is about having the courage to change culture. To be effective as a compassionate leader, I think it's also about understanding the core needs of those we lead in the workplace. And I've had the privilege, well, between 2017 and 2019 of co-chairing an inquiry on behalf of our General Medical Council into the mental health and well-being of doctors across the UK. And over the course of the last year, working with the King's Fund, an inquiry into the mental health and well-being of nurses and midwives across the UK. And to guide our work, we've used a well-established and well-evidenced model of core human needs in the workplace developed by 2 Americans. And we've called this model the ABC of core needs at work. And it is important, I think, that all leaders understand these core needs. If we are to transform the workplaces of doctors, nurses, midwives, other staff, then we have to understand what it is that determines people's well-being and motivation at work. And there are 3 core needs. The first is the need for autonomy and control, that people want to feel at work that they have choice, they have influence, they're not simply resources which are directed in a command and control way, so that they have choice about how to do their work most effectively within sensible constraints. And that's about having voice and influence. in the workplace for everyone who works with us as leaders. It's also about basic working conditions, and what we've seen in the course of these inquiries is people who have not been able to get nutritious food on their shifts, access to hydration, places to rest. We've talked to doctors and nurses who've been too tired to drive home after 3 12-hour shifts, and people who haven't been able to even take toilet breaks. I mean, this is kind of the basics of human control at work, where we're not able to satisfy our basic biological needs. And it's about also people feeling that they can influence work schedules and rotas, rather than feeling that they have no influence whatever when they have particular challenges in their home lives. And we see, I should say, good examples of where these needs are being met in different organizations across the UK and in Ireland. We also see that there are very few that are effectively satisfying all of these conditions. The second is the need for belonging. It is clear that working in a stable, supportive team is enormously protective of our well-being, and it's also the way we most effectively deliver healthcare. To be part of a team where you feel cared for and where you care for others, where there's camaraderie, is hugely protective of doctors and nurses and midwives' mental health, and also, as I say, determines effective care. And it's also about working in an environment, in an organization where there is a sense that staff are cared for, where there's a commitment to high quality care and compassionate care for patients, and similarly there's a commitment to high quality compassionate support for staff. And the third area that's really important in terms of people's basic work needs is the importance of fulfilling the need for competence, that I can do an effective job, I can make a difference for patients, for communities, that I'm able to do the work in a way that satisfies me. And we've seen in the course of these inquiries many examples of moral distress where nurses and doctors feel they're not able to deliver the quality of care they feel they should be delivering. And a key factor affecting that is chronic excessive workload. And chronic excessive workload, I think, is we've come to treat rather as the pattern in the wallpaper that we no longer see. It's the number one predictor of patient dissatisfaction. It's the number one predictor of staff intention to quit, and the number one predictor of staff stress. It's also associated with, among staff, higher levels of cardiovascular disease, addictions, diabetes, depression, family breakup. So it's vital that as leaders we address the challenges of chronic excessive workload. And again, we see examples of organizations that are doing this. There's a very large mental health and learning disability trust in London that regularly reviews with staff what activities they would minimize or get rid of altogether that they see as not adding value. And they give all staff the opportunity to vote on those, and then they mandate teams to go and implement change. They've eliminated 85% of clinical audit activities in the course of their work in doing this, and they are one of the top rated organizations in the health service in the United Kingdom. It's also about ensuring that people have effective, supportive, one-to-one supervision with their leaders, and ensuring that we are continuing to develop our skills and knowledge and competence through new assessments, new activities, through training and development. And all three of these needs have to be met for people to feel motivated and a sense of well-being in the workplace. We can't simply pick and choose between these. And I think we have to address these core needs if we're to not revert to where we were before the pandemic, but instead to transform our workplaces, because that's a necessity now because of the shortage of staff and the difficulty of attracting staff to our organizations. And the second key area I want to draw out briefly is the importance of team working. I've emphasized how important that is already. I've been working during the course of the epidemic on our COVID-19 task force on staff well-being, and currently on the Recovery Commission. And it's clear that team working has played an enormously important role as a protective role and in enabling the radical innovation I talked about at the beginning. I'm not going to go through all of the points on this slide because they'll be familiar to you, but it is important as we rebuild our teams to reunite around a really clear shared purpose with a limited number of clear agreed goals, 4 or 5 goals, and encouraging those in our teams to develop new and improved ways of working and to embrace the ways of working that have proved so positive and helpful during the pandemic. And that's a responsibility for all of us as leaders. I mean, I keep being involved in conversations about, well, how do we avoid the reverting to where we were before end of the spectrum and instead make sure we continue towards the transformational end of the spectrum. And that requires every one of us as leaders to take responsibility to ensure that we're embracing the new ways of working. And it's really important, as I've said, to promote belonging and to value different experiences from different professional groups. Multidisciplinary team working has to be the way forward in terms of a new flexibility and coordination. And that's about celebrating differences of professional background, of experience, demographic background, ethnicities, and differences of opinion, because having positive attitudes towards that diversity is associated with much higher levels of innovation. The third theme that I think is really important is that we've seen during the epidemic teams taking time out to reflect. I mentioned the chief executives of all of the London hospitals meeting twice a week to reflect on the situation and what they can learn and how they need to respond to it. And we've seen that reflection happening in huddles, in teams throughout our organizations. And our own work has shown how fundamentally important this is. It's important for us as individuals to take time out and reflect and be still, whether being in nature, meditating, whatever it is that we do. And our work with teams has shown that teams that take time out on a regular basis to review, to have debriefs, to have half-day away days or full away days, or even for ward teams to have a preparatory 15 minutes before the start of a shift and at the end of a shift, it makes an extraordinary difference to levels of productivity and innovation, to effectiveness. And a meta-analysis published a few years ago by Tannenbaum and Carasoli, based on data from 49 separate published peer-reviewed studies, showed that teams that take time out on a regular basis are on average between 35 and 40% more productive than teams that don't. Extraordinarily large effect. And so, you know, what that tells us is how important this reflective approach is, and it's the responsibility of leaders to ensure that that happens, I think. We've also seen the same effect at organizational level. We see it in the cultures of organizations. Those that are more reflective and focused on learning are much more innovative and productive than those that don't. So to summarize what I've been saying, it's about creating, us as leaders, creating the conditions for psychological safety. And I know that's a term you will have heard used quite widely. What our research over the years has shown is that psychological safety is created by compassionate leadership and by effective supportive team working, and having the basic conditions in place for effectiveness: a shared vision, a limited number of clear goals, 4 or 5 goals, and a climate of reflection and learning and innovation, rather than a blame climate or a fear climate, both of which will suppress learning and innovation. And it's about having frequent positive contact with those we lead. And I know that's been difficult during the pandemic with many teams connecting remotely, but it's vital that we find ways of having frequent positive contact with those we lead, whether it is through these artificial media or through face-to-face contact, because that builds trust and understanding. And it's about, as I said, valuing diversity and difference and having a positive approach to task conflict. Chronic interpersonal conflict is a disaster for psychological safety and for effective team working. Debate about how best to do the task when it's managed in a climate of positive mutual respect and commitment to finding creative solutions is really effective for our performance and for innovation. And I think we're very bad generally at managing those sorts of conflicts. They too easily slip into interpersonal conflicts. And it's about encouraging mutual support and compassion. And as a leader, about encouraging humility rather than hubris or narcissism. Narcissism is as Philip said, these strong men leaders is just a disaster for psychological safety and effectiveness. Narcissism is about 1%, exists in about 1% of the population as a trait. It's about 6% in senior leaders in organizations, and as you know, it's about 100% in the current American presidency. But anyway, what I want to conclude by saying is that when we create these conditions, we create the circumstances within which we can deliver high quality, continually improving and compassionate care and ensure high quality, continually improving and compassionate support for staff. But I think to conclude that in order for us to have the resilience and the capacity to pursue the agenda I've described and to model compassionate leadership, we first have to have the courage to be self-compassionate. And what that means is, in order to be compassionate towards others, we have to first take care of ourselves. And that involves the courage of paying attention to ourselves, being self-aware, aware of the challenges we face in our work, from moment to moment, day to day, week to week, and aware of the challenges indeed in our lives generally. And it's about understanding those challenges and caring for ourselves, empathizing with ourselves, and then taking intelligent action to help ourselves in order we can be the best leaders we can be and stay close to the core values like compassion and wisdom and courage, which enable us to develop closer, more authentic connections with all of those we lead and indeed all of those we interact with. So I think it begins with the courage of compassion. So go Reb Mahbo, go. Thank you very much for listening, and I look forward to our discussions. Thank you.